So then people I've talked to say, well, this must be about race. This is about the large proportion of African Americans that we have in the South. And so therefore you can say, okay, well, let's see what would happen if we look at non-African Americans, or we look just at Caucasians. So we do that, and we look at age-adjusted death rates. This is older data, but it is largely true still today. And here, what you have is black males and white males. Here you've got black females and white females. Well, that's kind of goes against our race argument. We look at heart disease, and you see the same thing. Then you start thinking, I'd better move regardless of my race, because I'm really in trouble being here. I'm not, maybe, yeah. So if we look at cancer rates, look at stroke, we're looking at all races before, we find the largest burden of disease in our states. So if you're looking at HIV, this is a great place to work. If you want to go into chronic diseases, HIV possibly being one of them, this is a great place to work. You can look at diabetes, you can look across different diseases. Our states are also poor, and this is a problem. If we look at births that are financed by Medicaid as a percent of total births, we find that the largest proportion are these states down here. And we'll see if this works. All right. This always scares me. So if you have a large proportion of births financed by Medicaid, why am I focusing on that? Well, that means that the state is responsible, in a sense, for that proportion of individuals. It's kind of just an indicator that's out there. And here you can look, this is 2005 data. In North Carolina, our state pays for 58% of the births. If we move to Georgia, it's 57% of births. With Mississippi, it's 62% of the births. So what does that also mean? Well, that means that your tax base is really low. Okay? So you're in this AIDS class, and I'm telling you this is not just about a disease. This is about everything from federal, national policy, to state policy, to local communities, to experiences that people have in their families, to the individual themselves. So your tax base is really low. So you figure, 40%, 30% of the population is paying for the health care of everyone else, right? Because Medicaid is a federal, state-funded program. Our ADAP, the AIDS Drug Assistance Program, that's also federal, state, also relies on state budgets. And then if we look at Medicaid spending per enrollee, you'll find here the darker is a lower amount that's spent on average per Medicaid enrollee. Well, yes, they're going to spend less per person because there's less money there. So even though the states, if you look at a total state budget, may be paying, North Carolina could have a Medicaid budget that proportionally is the same as New York, and maybe even slightly less. They don't have the money to pay for good health care. So the ADAP funding is lower, so the AIDS Drug Assistance Program. So you're not eligible for Medicaid, you're uninsured, there's a huge problem here. So you're not eligible for Medicaid, you're uninsured, you don't have enough money to pay for the medications yourself or care yourself, you're not privately insured. So you turn to ADAP, our Ryan White funded program, and our states have the lowest amount that we pay per person in ADAP. And we also, most of our states, have waiting lists, meaning we have people in this state, so I'm going to Tanzania and Ethiopia and Malawi, and we're trying to cover, and there's a great will and desire to provide medications for everyone. We're not doing it here in North Carolina, and that really is a crime. And it really, and I am involved in all of this, and it's really amazing. Medically needy programs are Medicaid programs, where in many states you don't meet eligibility just based on your income, but your medical expenses are so great that when you count them in, you're below whatever the eligibility is. Most of our states don't have them, whereas other states do. So resources are a big issue. So we go from qualitative studies that are very appropriate and very necessary, and you don't choose between a qualitative study and a quantitative study. You don't say, well, I have qualitative skills, therefore I'll address each question with qualitative data analysis. And, or you don't say, I'm a quants person, so I'm going to address every question with quantitative research. You have to choose the method based on what the question is next. So through this work, we developed a lot of hypotheses. We then had to have a large survey with lots of numbers to test our hypotheses. So we did the largest study of people who are HIV positive in the Deep South. We followed over 600 people over a 4-year period, consecutively sampled in infectious disease clinics in North Carolina, South Carolina, Louisiana, Alabama, Mississippi, and Georgia. We threw out the Mississippi sample. I can tell you why at another time if you would like. And we asked them whether they had, one of the things was experiences of trauma, because one of the things that came through in this book was how many of the patients, how many of the people with HIV, how many of the individuals, our participants, had experienced very severe childhood trauma. And I had expected to have quite a bit of trauma reported, nowhere near the extent of what we saw. People witnessing parents who were killed, people coming home, lots of alcoholism in the family, coming home sleeping in chicken coops because the father was shooting his gun off, or the person who was there, the male person who was living in the house, kids having to wear dirty clothes to school every day and being terribly embarrassed and feeling terrible about it, parents who couldn't get their kids to school on time, having no time to do homework, not having enough to eat. 25% of kids in North Carolina, at least as of about 5 years ago, go to bed hungry at least one night a month. Lots of feelings of hunger. And these are kids who went to school with lots of needs that were far beyond learning math and reading. They were not the students, the teacher's ideal student. And our teachers, you can imagine, aren't trained to work with these kids when they're trying to meet the needs of 30 other kids. So the people who we talked to lit fires in garbage cans. They beat people up. They did what they could as they got older. And one of the themes was that they started using drugs. And you can imagine, so we now know that experiencing trauma as a kid, or a lot of trauma, being in a war, can cause post-traumatic stress disorder. We now know that we can actually see how that changes brain functioning. We can see it on MRIs. We have therapies for post-traumatic stress disorder. It creates kind of a low level of anxiety all the time. So imagine a 13-year-old who's been beaten and kind of surviving on their own. The gal in here whose father would get drunk each night and touch her breast. She tells the social worker who comes to the house because she was looking for help. The social worker decides to have a family meeting with the guy and his girlfriend. They deny it. She's kicked out of the house, gets married at age 15. So imagine these kids who are going through all of this, and at age 13, 14, 15, they have their first taste of alcohol. And maybe you and I would say, wow, we're having kind of cool, we're having some alcohol, we're at our parents' school party. And they're saying, oh my gosh, I feel calm. I feel like many of the people in this room feel right now. I'm feeling it for the first time that I remember. I don't have that tingling under my skin. I say, wow, I'd like to keep doing this. And I can't trust these adults, and the teachers haven't helped me, and the social workers haven't helped me. I have no trust in the system. that's going to be able to help me. So I'm going to keep doing this alcohol. Alcohol is a major problem in our states. We talk, when you talk in the HIV world, everyone's talking about injection drug use, because that's, you're putting the blood right into your arm, right? Not using clean words. In our states, alcohol is a major problem. So we take this and we start asking. Large cohort following over time. So, tell us about your lives. So our sample was representative of people in the South who are HIV positive. Most of the women, we had about 29% female. Most of them have children, very important to know, 69%. Vast majority were poor and underinsured. So this was not, in this sample, is people with case managers, so they were, by definition, poorer than others. But the majority of folks in our sample were uninsured or on Medicaid. We also had people who were very well educated and who were wealthy. They were highly mobile. We don't talk about more since I've been living here, but a homeless population in our states, but we have a large proportion of homeless people, but they're going from place to place. They go to an uncle's house, they go to a friend's house. A large proportion of women who are HIV positive who are exchanging sex for lodging, particularly for their kids, and some kind of income, but living in different places. So highly mobile, usually staying in the same area, so you can follow them over time, but they're going to move from one street to another. Lainey does some of this. They report history of substance abuse, screen positive for anxiety, depression primarily. And they report as children, and people say, well, they're thinking backwards. This is retrospective, right? So who knows if they're telling the truth or not? I don't know if they're telling the truth. But what I do know is that if you asked everyone here, you probably wouldn't get rates this high. So 21% reported not having enough to eat as kids, 34% reported parents who were problem drinkers, 12% reported parents getting too high or drunk to take care of them. Before the age of 13, 25% were sexually abused, men and women, and men who do not have sex with men today. So a stereotype that we have is that men who are sexually abused as kids tend to be men who are men who have sex with men later, either because of biological predisposition, because whatever that is, whatever, it's just something that we have in our heads. What we're finding is that men who don't have sex with men, who are heterosexual men, engaged and having multiple relationships now, also were sexually abused as kids, those who are HIV positive. 14% had intercourse with someone 5 years or more older, and those people used force or threats. 54% of those encounters were with their parents, guardians, partners of parents, brothers, and other family members. More than a quarter were attacked in a way that made them feel like they could be killed, that their life was in danger, that they could be seriously harmed. What we are looking for in this checklist is things that create post-traumatic stress disorder. So those potentially traumatic events that later can cause post-traumatic stress disorder. 7% had a parent who went to prison. I put in that 10%, when we divide the sample, 10% of minority respondents had a parent who go to prison. But again, also, Caucasian participants had parents who went to prison. 10% had been in foster care. This is really important to me because if you look at the population out there, the population that's in foster care is probably, I actually had some students look at this data at one point, but it's 0.00 something. 10% of people coming into the ID clinic here were in foster care. That says something pretty amazing and really important about our foster care system. What happens to kids before they get into foster care, but also that our foster care system, this is not to say there aren't, and there are fantastic foster care parents out there. There are places where it really succeeds. But this is just very striking and important and needs to be followed up on. They reported that their parents were depressed or mentally ill. This is where the interviewers said, we asked the interviewers, where are people most uncomfortable? Oftentimes when we do surveys in the US, people are really uncomfortable talking about money, and they're uncomfortable talking about sex. In our interviews, where they were most uncomfortable was talking about their parents. And the interviewers really felt, if anything, they were underreporting here. So 6% said they had parents who tried to commit suicide. Well, we don't know if that's true or not, but 3% were actually successful. Of our participants, again, quite amazing. 17% had a family member killed in a crime, 43% had seen someone seriously injured or violently killed. Okay, so this chart here is to show you that male and female rates of sexual abuse are pretty similar. So this is sexual abuse of men, sexual abuse of women before the age of 13. About 25%, males being slightly less. This is sexual and physical abuse. We've got a little higher rates here. And then once we go beyond the age of 13, that's when women now experience more sexual abuse. So once you're beyond puberty, women continue to experience sexual abuse, and that stops with the men. So we do find indeed that nearly 20% of women, 17% of men have post-traumatic stress disorder. They scored high enough on the scale to be scored as PTSD. They have lots of depression, phobia, and are willing to talk about it. In our states, go back to those funding slides, we don't have funding even for our HIV services, let alone to treat substance abuse and mental health disorders with HIV, and we're trying. We get grants. Laney's involved in grants. We try and figure out how to provide holistic care in a way that makes sense. And in fact, when we do it, we do find that it reduces the cost to the system because people don't have as many opportunistic infections, they don't have as many emergency room visits. And so they maintain a more chronic, stable rate. And we have studies to show that. But we can't get it funded because it's really not politically feasible in our state. So it's very, very difficult. And yet the ramifications of not dealing with post-traumatic stress disorder, mental health issues, the depression, is that we see these sorts of effects on adhering to your medications. So if you've had no traumas, the non-adherence rate is 9.5. One trauma, one potentially traumatic event, 16%. Two traumas, 26%, not going to adhere to medications. Going up 5+, and it continues a little bit after this. If you've had 5 or more potentially traumatic events, 34%, those people are not going to adhere to their medications as they should. We have, again, really good interventions. We have good medication, but also, and also really good cognitive behavioral therapy, dialectical behavioral interventions that we can do with people who have post-traumatic stress disorder. We also found a high level of distrust in the government, meaning that people believed that the government created AIDS as a way of killing off minorities. People still believe that today. And in fact, 1 in 4 people walking through the clinic here at UNC, at Duke, wherever in all in our states, believe that our government created this disease. And in our case studies, the theories around why the government did this were really pretty sophisticated. So it was, our government created it. One was just, I've been on welfare, my parents have been on welfare, we've been on welfare for generations, the government needs a way to save money, so they're going to do it by killing off poor people and people they don't like. 2, We had 3 people in the military in our case studies. All 3 of them believed that the government created AIDS. They said, you know, I know them. I know they would do this. This is something our government would do. And others said, you know, I think it was part of biological warfare, and it got out of hand, and then we went and we tested it in this African country called Zaire, and then, you know, they should have known it was going to come back to us, and now it has, and now they don't know how to stop it. To other people saying, and we found this in the larger study also, saying we know there's a cure out there, they're just not giving it to me. They only give it to the wealthy people, they give it to white people, but there's a cure out there. One woman says, you know, I know my doctor, I love him, I asked him, I went in, talked to him, I said, Dr. X, if there was a cure out there, would you give it to me? And he said, you know I would give it to you, of course I would. She left, she said, I really like my doctor, but I know there's a cure out there, they're just not giving it to me. So think about that, that's who's coming through our clinic right now. Today, when the clinic was open, that's who's coming through the clinic. So people are coming in, those who are coming in, who are willing to come in for help. A large proportion are saying, I'm here, I'm trying to get help, I'm taking these meds, but really how does this fit into the grand scheme of the government trying to kill us off? And then we've got these waiting lists. They won't even give me medications. I'm on Medicaid for a while, then I'm off Medicaid, so I can't get my medications, I go back on. Now I have drug-resistant virus, but it was because I couldn't get my medications. I tried taking one every 2 days because I wanted to save my medications because I didn't have enough money to go and get a refill, so I was trying really hard to save them. And a majority believe that information is being held back in a negative way from the population and from physicians. And I was really interested in this very close bond that the respondents had in the case studies with their case managers and physicians, and people really believed that the physicians and case managers were being duped. That was a word that was used. That they just didn't understand. That they haven't lived on the streets, they don't understand society, they don't understand the way the world works like they do. Because they've experienced it, they've seen it, they have seen how the system works against you. Why do we care about trust? Well, who cares where people think the virus came from? It really does not matter to us as clinicians. Well, we care because trust then predicts your clinic visits. So if you trust your providers, you're more likely to go to clinic visits. That's a good thing. You're less likely to end up in the emergency room. You're more likely to take your medications. If you're saying, I don't believe the government created this disease, so trying to make these go in the same order, you're more likely, even controlling for trust in providers, to go to regular clinic visits, not show up in the emergency room, take your antiretrovirals. And an important thing here, if we go back a slide, it is true, and most studies that you'll see will talk about African Americans in the United States thinking about Tuskegee, not trusting the government. It's true. And if you put this in a regression analysis and controlled for minority status, you would find that minorities are more likely to believe this. But 20% of Caucasian men and women also, so 1 in 5, a little over 1 in 5, also believe this. And importantly, as we've looked at the data and followed this through and analyzed and again looked at people longitudinally, past traumatic events trump everything, meaning they are the most significant variable in every single analysis we do. And our group is all collaborative, it's interdisciplinary. We've got physicians and epidemiologists and statisticians, we've got social workers, we're all working together. And it was not the hypothesis of many of our collaborators going into this that trauma was going to be, particularly the clinicians, the ID docs, that trauma was going to be the most important variable. But we found that when you control for everything, that it is the biggest predictor of high-risk behaviors, drug use, multiple sexual partners. It's true, again, of men who don't have sex with men. So when we look at our states where we do have a large proportion of people being infected by through heterosexual sex. We have a large proportion of females who are infected, who are not injection drug users. They're more likely to have multiple partners, to not use condoms, and to go out and be using different kinds of drugs, crack and alcohol and things like that. Trauma likely predicts morbidity. It also predicts mortality. So even if you stay on your medications, even if you're going to your clinic visits, even if you're controlling for other things, you're still more likely to die more quickly if you've had a traumatic experience as a kid. We now see across different diseases, neurological disorders, intestine, that trauma is very important in predicting morbidity and mortality. Importantly, what Brian Pence has just really teased out with the data is that even when you control for depression and anxiety, that trauma, that having had the experience of trauma, is still as important or more important than current mental health symptomatology. That's really important. Okay, so we think about, you have a traumatic event, and then you have your mental health symptomatology, which we measure in depression, anxiety, phobias, and then you're not adhering to medications, not going to your clinic visits, having multiple partners, not using condoms, doing all these things, right? So we assume that that's the line, that that's kind of the causal pathway. What we've discovered is that trauma does work through that pathway. So you are more likely to be anxious, experience anxiety, more likely, but that it also acts kind of on its own, which when you talk with psychiatrists really resonates with many of them saying yes. And this is one of the reasons we get so upset about having to bill by DSM-4 diagnosis, because we know trauma, having experienced these things, it makes a difference in the pattern of your behavior and how you interact in the world and how you're thinking about the world. And if you're thinking about us and them, and those behaviors protect you as kids, but they're not helping them as adults now. So what do we know? We know, you think about the maps, you think about all the diseases, you think about behaviors, you think about what you've seen here. And poverty is a big driver. Living in poverty, we know from studies not related to HIV at all, that for each percentage increase in poverty, there is an increase in family violence. It is when factories close, we know that family violence increases. It's that poverty is an extreme stressor in our country. We also know, of course, that it decreases access to care. It's harder to live healthy lives. You know about food deserts. If you're in Northeast Durham, to get fresh foods is really expensive, and you can't get there unless you make a huge effort. And there are fewer options for the future. So when you're thinking about, oh gosh, the kind of the future goals that you have sitting here, everyone here, at least came when they started school, was hoping that there would be some kind of future out there that you're moving toward. Hopefully that hasn't been beat out of you yet. And when you don't have those future options, it becomes a lot harder to say, I'm going to spend all this money and my family's resources to get these medications, to go to the clinic, to hide my disease, to do all of these things so that I can live 15 years longer? Well, I don't know what I'm doing next week. And literally people are saying that I don't know how I'm going to pay my phone bill. I don't know how I'm going to keep the electricity up. I don't know how I'm going to keep my kid in school. A lot of the people, though, 69% of the women who are parents, their kids are having a hard time. And those women are struggling to be good parents, and they talked about a lot with us in our case studies, and it's really hard. We would go back, and when you've grown up with parents who beat you and who are substance abusers, it's hard to learn how to parent, and we don't have parenting classes out there for people. So people are worried about other things. They're not worried about getting tested for HIV. As one person said, having HIV is just icing on the cake of a bad life. No? So when you don't have those future options, it really changes how you're thinking about what you're going to do today. We know that we've got really high rates of other sexually transmitted diseases. People are not being treated for those either. For the same reasons, they're not being treated for HIV. They don't want to go to the health department where families know each other and see if they have syphilis or gonorrhea, herpes. And when you introduce, well, HIV is hard to transmit heterosexually. When you've got STIs, it becomes much easier. And we've got all of the other comorbidities. Another thing to say is with our prescription drug programs with Medicaid and others, there's a limit with Medicaid. There's a limit on the number of prescriptions you can get. Many of the people who we work with also have diabetes, and they have cancer, and they have heart disease, and so it's not only the complexity of HIV, it's the other diseases that people are facing also. We've got all the issues of race. I started out by saying a definition of the Deep South is these are states where we actively promoted slavery. I've done some look at counties where you had the highest proportion of slaves, very agriculturally rich counties that are now quite poor, and rates of HIV in those counties. And I believe that, so stepping away from my quantitative hat and moving into more ethnography and history, that when you have a culture, whether it's in India with the caste system or here with slavery, that when you teach people that you're born into a situation that you deserve, whether it's good or bad, that you make hope for the future for many people, and it not exist. The term white trash was developed here in the Deep South also. So it's not, so there is the racism that's there. There's also, if you grew up in the trailer park in Anson County, your parents were alcoholics, didn't go to church. Every teacher you have, and people in the health department and the families around there, all know your family. And they know that you, from the moment you're born, that you're never getting out of that place. No one's going to step forward and help you. And yes, there are people who move out and who are able to overcome that. But it's an awful lot harder. And as an African American, growing up in our country, facing the racism that is here, to come out as being gay, as being a drug user, as having HIV, another sexually transmitted disease, is just, for many people, not something they're willing to do to their families. They don't want their mom to know. They don't want to disappoint their families. There's so much pressure on the family already. They don't want to do this to our families, to our communities. And so people hide their own disease. There's been a perception in North Carolina and South Carolina that there's a cancer epidemic going on, largely HIV. These isms, racism and sexism, homophobia, are really, really important to overcome and to address. So it's really important to have good medications. It's really important to have good vaccines. But you're not going to be able to stem this tide until we're also able to address societal issues that are going on. The willingness to fund medications, the willingness to fund programs that can address the issues that we're facing. State level poverty, we don't usually talk about that, but that's an issue also. We get mad at the state, I get mad at the state. What are you doing? We need more help. Our states need more help also. At one point we were engaged in debates over the last Ron White reauthorization, and Hillary Clinton's office called and was really angry, saying, why are you taking money away from our state? It was her lawyer. They were very good, very fast speakers. And we say, we're not trying to take money away from you. I don't care how much money you get, but we need help. And we're all in the same country. Shouldn't, you can fight for these needs also. Our states are poor. And we've talked a lot about funding. So funding, policy implications. I'm a policy person. I translate research into action and policy. We need more funding. We need to treat STDs. We need culturally appropriate care and prevention. We need access to medications, access to testing. We need to talk about the importance of it. We need to deal with people's hopes and futures and aspirations. We need to address families. We need to get in and work with high-risk families. We need to work around parenting, and we're starting to have interventions that do some of this, but again, funding. We need to include mental health and substance abuse services, and we need to work on trust-building activities. So in the end, it's not just about treating the disease, it's about all the things that go around it. And to go back to the beginning, that HIV is a lens through which we can see what's going on in our society. And we really see where there are large holes that need to be addressed if we're going to get this under control. And that's it.